Hello everyone, today we're talking about lymphatic system. To maintain your fluid homeostasis, the net flux of filtered plasma has to be balanced by the lymphatic return to the circulatory system. So when we talk about edema, we usually talk about capillary leakage. However, it is just a part of the story. We talked about interstitium and its role in edema formation in the previous lecture. In this, we'll learn about lymphatics and how they affect the fluid management and edema formation. Let's take congestive heart failure as an example. In a recent study, investigators looked at your lymphatic reserves in heart failure with preserved ejection fraction, and they found that these patients with heart failure accumulate edema fluid at much lower interstitial pressures than a healthy control. They found that the heart failure patients had skin lymphatics with larger diameter, rarefaction of both small blood vessels and lymphatics, and lower expression of lymphatic differentiation and functional markers. So we have been taught traditionally that in heart failure, you have increased microfiltration from the capillary leakage due to your elevated CVP and congestion. And initially, there is some increase in lymphatic drainage. However, these investigators found that in fact your microfiltration drops down and your lymphatic drainage drops down to a much lower level than your microfiltration. And this results in accumulation of your interstitial fluid, causing edema. So in heart failure, there's reduced capillary surface area along with reduced lymphatic reserves. And as your lymphatics dilate with increased congestion, the valves become more incompetent. So edema in heart failure is not only from the capillary leakage, it's also from dysfunctional lymphatics. Similarly, in preeclampsia, the reason you form edema is not because your filtration has increased. In fact, the filtration decreases in these patients, while your lymphatic drainage suffers even more. This results in interstitial accumulation of fluids. Similarly, lymphatic dysfunction has been observed in sepsis, burns, shock, major surgery, etc., which affects edema formation. You need to know about lymphatic system, and we'll cover this topic today. We'll understand how lymph is formed, how the lymphatic system is structured, how lymph moves in the lymphatic system, and finally, what factors govern lymph flow. Once you know how the system works, you should be able to figure out some treatment plan for your patients. Lymph is the accumulation of fluid in your interstitium from your net capillary leakage. We talked about this in our previous lecture. Please review my earlier lecture on Starling and modified Starling equation. But the net capillary filtrate for the whole body is about 8 liters per day, excluding kidneys. Next is the movement of lymph from your extracellular matrix to the lymphatic capillaries. When they measure the pressure in the lymphatic capillaries, it comes to be approximately 0. And we know from the previous lecture, the interstitial pressure adjacent to the capillary is negative to the order of -2 to -5. So the question is, how does this interstitial fluid move from your interstitial space to a lymphatic space? And the answer is pretty peculiar. The pressure in the interstitium is not always negative. There are muscle movement and arterial pulsation, which cause intermittent positive pressure, and that results in net flow of fluid from your interstitium to the lymphatic channels. They found that pressure gradient as low as 0.09 millimeters of mercury per millimeter is sufficient to drive large amount of filtrate from capillaries to the initial lymphatics. This is a study which examined the interstitial pressure changes with cardiac and respiratory cycle, and you can see that the pressure fluctuates and it's not one constant number. Therefore, the movement of lymph is cyclic and not continuous. The next important thing that you have to remember is as your net capillary filtration increase, the pressure generated in the interstitium will depend upon the compliance of the tissues. And there are organs with low interstitial compliance like brain, kidneys, liver, etc. and high interstitial compliance, for example, subcutaneous tissue. And this is important because the tissues with low interstitial compliance will have higher increase in your interstitial pressure for the same amount of volume that is filtered from the capillaries, thereby decreasing the hydrostatic pressure gradient and slowing down the edema formation. So the interstitial pressure are the main driving factor for the lymph flow. Normally, the values in the skin is negative. However, as more fluid accumulates in your interstitium, the pressure tends to become more positive. And as soon as the pressure crosses 0, there is a sudden rise in flow of lymphatic fluid. However, there is a max which is about 10 to 20 times the normal flow. To prevent lymph from going back to the negative interstitium, their functional one-way valve system which are primary valves. These are connected to your interstitium via anchoring filaments made up of collagen type 7. There's also evidence that there is some vesicular transport involved in lymphatic formation, and this may transport larger molecules. So lymph formation is facilitated by small cyclic variable hydraulic pressure gradients along with some vesicular transport and functional one-way valve system. Once the fluid enters initial lymphatic capillaries, it is diverted towards the afferent lymphatics. The movement of lymph in lymphatic system involves two processes. First is your pumping, and second is your presence of one-way valve. And the collecting lymphatics are endowed with smooth muscle cells, which act as lymphatic pump and have regular valves, which are called secondary valves. These are semilunar valves, and this allows for one-way flow of lymph. The pumping of lymph in the lymphatic system is promoted by two types of forces, extrinsic and intrinsic. Extrinsic forces like skeletal muscle contraction, breathing, peristalsis, and arterial pulsations help movement of about 2/3 of the lymph flow, while the contractility of lymphatic smooth muscles account for about 1/3 of lymphatic flow. Lymphangion is the functional unit of lymph vessel that lies between two lymphatic valves, and this area has its own pressure volume loop. Lymphatic contractions are triggered by an action potential in the pacemaker lymphatic microvascular cells, and the action potential then propagates rapidly from cell to cell over the length of lymphangion, as you can see in this figure. Estimated ejection fraction of a normal lymphangion ranges between 70 to 80% and can generate 20 to 120 millimeters of mercury pressure in your lymphatic system. This study looked at the frequency of contraction, velocity of lymph flow, and the pressure generated in the lymphatic system. You can see that the pressure generated in your lower and upper extremities can be of the order of 60 to 80 millimeters of mercury. This figure shows lymphatic contractility rate, pressure, and velocity of flow in different parts of the body. The afferent lymphatics will end up in a lymph node, and they will deliver around 8 liters of lymph to the lymph nodes every day. The fluid in the lymph also comprises of a lot of cells in the lymphatic system, and these have immunological role. You can see that in afferent lymph, there are a lot of B and T cells, but they also have dendritic cells. If you remember, dendritic cells capture and process antigens to present to the T cells, and the whole lymphatic system is designed to have a continuous recirculation of memory T cell through the peripheral tissues, and this facilitates and enhances your immunosurveillance and results in rapid responses to reinfection. About 4 liters of the 8 liters that was presented to the lymph node is reabsorbed in the lymph node in the nodal arteries, and this happens because of the oncotic pressure difference between the lymphatic flow and oncotic pressure in the capillaries. The remaining 4 liters of lymph proceeds to the efferent system. Efferent lymphatics also have semilunar valves and smooth muscle pump so that they can move the lymph back to the circulatory system, and this comprises of your thoracic duct and your right lymphatic duct. So let's look at the factors affecting lymphatic flow. The most important thing is your interstitial pressures. Next, you need to have functioning valves. That means both primary and secondary valves. Next is the efficiency of the pump, and that would be constituted by contractility of your lymphangion, muscular activity, cardiac and respiratory movements, gravity, intrathoracic pressures, and lipid accumulation in the interstitium. Interstitial pressures are the most important thing that governs the flow. As the net capillary filtration increases, your lymphatic flow increases because of increased pressure gradient, increased hydraulic conductivity, and increased cross-sectional area. However, there's a limit to how much lymphatics can remove the lymph from the interstitium, and that is because lymphangions have maximum dilation capacity, and as they dilate, they become more incompetent. So lymphatic can increase the flow up to 10 to 20 times the normal flow. Just like any other contractile tissue, the contractility of lymphangion, that means increase in tone, amplitude, and frequency, depends upon some chemical factors. Alpha-adrenergic stimulation and dopamine stimulation increases the contractility. Mediators like bradykinin, serotonin, substance P, and muscarinic receptor also increase tone, amplitude, and frequency of lymphatic contraction, therefore increasing the lymphatic flow. On the other hand, beta-adrenergic receptor activation and endothelial nitric oxide synthase stimulation decreases tone, amplitude, and frequency of lymphatic contraction. Similar decrease is observed with calcium antagonist and acidosis. Nitric oxide is the major regulatory component and suppresses the lymphatic pumping. And you can see that increased nitric oxide results in more relaxation of these vessels and less contraction frequency. So the way to remember is nitric oxide results in no lymphatic movement. And this is really important because in any inflammatory state such as trauma, sepsis, burns, major surgeries, your lymphatic contractility is dysfunctional and results in worsening edema formation. Inflammation also prevents normal functioning of the primary valve. And since these valves become dysfunctional, there is a less clearance of fluid from the interstitium, and therefore the inflammatory mediators tend to accumulate and worsen the inflammatory reaction. Muscular activity and gravity aid both in venous pumping and movement of lymph from peripheral to central areas. So dependency and mobility aid in edema formation due to both decreased lymphatic flow and increased venous congestion. So walking is the best way to prevent edema in your patients. Walking and moving reduce pedal edema because they reduce the standing venous pressure. When you walk, your normal standing venous pressure, which is around 80 to 90 milliliters of mercury, drop down to 20 to 30 millimeters of mercury. This will reduce net capillary filtration and decrease edema formation. Interstitial lipid accumulation, as seen in obesity, also affects your lymphatic function. There is a perilymphatic accumulation of iNOS expressing macrophages and alteration in lymphatic endothelial cell gene expression, which results in lymphedema, tissue swelling, and fibrosis. Leptin also suppresses lymphangiogenesis. Therefore, in obese patients, they will have decreased lymphatic density, heightened lymphatic leakiness, and impaired collecting lymphatic pumping. These all will predispose to edema formation in obese patients. Positive intrathoracic pressures can also adversely affect lymphatic flow. You need negative intrathoracic pressure, which provides a favorable gradient for thoracic duct filling during inspiration. When you apply positive intrathoracic pressure, this beneficial effect is lost, resulting in decreased lymphatic flow. Increased intrathoracic pressures also elevate CVP as some of the pressure is transmitted to the venous system. And this has got two effects. First, it increases your lymphatic production because elevated CVP results in more venous congestion. And it also reduces lymphatic drainage because you need a higher pressure in the lymphatic system to overcome the central venous pressure. In this study, they compared PEEP of 0 with PEEP of 15 with lymphatic flow. And you can see that the lymphatic flow drops significantly when high PEEP is applied. However, some of the lymphatic flow is regained as the time goes on, though it never reaches the flow generated by PEEP of 0. Lymphatics have longer time for clotting because they have more anticoagulants and less procoagulants. However, in inflammation and in cancer, you can have release of factor 10 by lymphatic endothelium, and this can trigger coagulation cascade and can cause blockage of lymphatic vessels and lymphedema in the inflammatory area. So let's look at how to improve edema due to lymphatic dysfunction. The first step is to reduce net capillary filtration, and this is difficult to achieve, but you can use your IV fluid with judgment, monitor your eyes and nose, and reduce venous pressures where applicable. When you drop venous pressures, you reduce your net capillary filtration. Usually there is not much we can do for underlying physiology, as your permeability of your capillaries and your Staverman's constant are properties of the disease itself and are difficult to change. Increasing your plasma oncotic pressure with albumin is not going to help you much. Next is applying compression stockings. This helps increases your interstitial pressure, thereby decreasing the edema formation. You can improve the intrinsic pump function by treating inflammation. Remember that increased level of nitric oxides are the main culprit behind reduced lymphatic activity. We know that increased tone amplitude and frequency can occur with chemicals, which unfortunately are not under control. However, you can use warm compressors for localized edema. The other thing that you have under control would be to prevent local acidosis. Understand that local pH is different from the blood pH. And to prevent tissue acidosis, the best way to achieve it is to achieve good perfusion to the tissues. Next, improving extrinsic pump function, and this you can achieve by increasing muscular activity. That means increase your mobility of your patient, set them up in the chair every day, and make sure that you change their positions. You can use gravity to your advantage, raise the affected area, and avoid prolonged sitting with dependent legs. Also, reduce intrathoracic pressure by optimizing your PEEP on ventilator. So this completes the whole cycle of edema formation. You should be able to understand what are the factors governing net capillary filtration rate, the role of interstitium in edema formation, and role of lymphatics in returning that edema fluid back to the circulation. Once you apply all these three principles that you have learned in the past few lessons, you should be able to manage your patients more effectively. These are the references. The link would be in description below. Thank you.